дојдовте во толку голем број да присуствуваме и на предавањето на професор Holger Lode, кој што за прв пат претстојува во Македонија. Тој е познат доктор, специјалист од областта на педиатриска хематоонкологија и ценет експерт во нашата област. Предавањето ќе биде на англиски јазик и затоа јас ќе продолжам на англиски да го поздравам професорот и другите наши гости. Dear Professor Lode, thank you for coming to Macedonia. Dear Lourdes, thank you for you. I welcome you in the University Clinic for Children's Disease. Warm welcome in Macedonia. I want to say some words for the introduction of the Professor Lode. He is a German specialist for pediatrics. He is professor and chair of the Department of General Pediatrics and the Pediatrics Hematology and Oncology Department in the University Medical Graduate. He is also the director of the Center of the Pediatric and Adolescent Medicine in Virtual Germany. Professor Lode made a very big contribution and he is well known for his clinical and scientific work, in particular on immunotherapy for neuroblastoma. He participated in many clinical trials, maybe more than 20 as a primary local investigator, so he is very known in the field of pediatric hemato-oncology. He is a member of many international associations, German, European, and American Scientific Association, and he was published more than 140 original scientific papers. For the last, I want to point that from 2015, Professor Lode is a medical expert of EMA, and from 2014 he is a member of the advisory board of European Association of Pediatric Hematology for neuroblastoma, and chief of the immunotherapy committee, and member of the executive board of COPEN. This is a very important members for all of us. So Professor Lode has a very big contribution in the field of research, also in clinical practice. It's my great pleasure to have you here today for this presentation. We are very proud for this. I want to say welcome once again to Dr. Lourdes. It's very nice to see you again now in Macedonia. I'm very proud for this. She is a medical doctor, PhD, and now she is a medical director of the Recordati rare disease for the Central and Eastern Europe. Welcome once again in Macedonia, and thank you very much for your help to organize this presentation. And in the end, thank you very much to Eva and our dear friends Vjekoslav. Vjekoslav is business director for our region, so they help us to organize and invite Professor Lode to be our guest here. And in the end, thank you very much for Angelina for her contribution in the organization as well. So thank you very much for all of you. I invite Professor Lode for your speech. Thank you.
So thank you very much for the very kind introduction, and also thank you, of course, for organizing this, making it possible, and having me as a guest here in your department. It's a great honor for me for the first time to be in Macedonia, and I'm very happy to talk to you about some work we have been doing over the last, let's say, almost 10 years now, And if you have questions, please don't be afraid to ask. I'm very open to address them. If they pop up in your mind, just interrupt me. If something is unclear, I'm happy to talk to you directly about it. So I understand that there's not only professionals and very highly educated directors and professors, but there's probably also some residents and maybe also students here in the room. So therefore, I made also my presentation looking at more basic aspects of neuroblastoma, but then also talk about the key components of the treatment, and then, of course, focus on the immunotherapy part, because this is the new aspect that we can use today to manage patients who have high-risk neuroblastoma. So what are the key diagnostic steps in high-risk neuroblastoma? And let's first have a look at the disease by itself. It is a disease that occurs from the sympathetic nervous tissue. So we have the sympathetic nervous tissue all over the body, in particular located in the adrenal glands. This is the main site where we have a lot of sympathetic nervous tissue in the medulla of the adrenal gland. But then we also have the paraganglia region, which has a lot of the sympathetic nervous tissue, and this is in the thorax and also in the abdomen. And this explains us also where we have usually the primary tumors of neuroblastoma. So they are mostly in the abdomen, because they originate from the adrenal glands and also from the paraspinal ganglia of the abdominal region. So we have about 60% primary tumors in the abdomen. However, we also have 30 to 40% in the thoracic region, because we have that sympathetic nervous tissue also in the thoracic cavity, and sometimes we have it at the same time in the thoracic and the abdominal region, which is for the surgeon always a very challenging situation, because they have to open two cavities to do a surgery. So this is sometimes very, very difficult, which is why we usually follow a neoadjuvant treatment approach. So we try to shrink the tumor first before we send the patient to the surgical theater. Okay, so we have the local site, but we have the big problem of neuroblastoma that in about 50 to 60% of newly diagnosed neuroblastoma, we have metastatic disease. And the metastatic regions are shown on the right side of this particular slide. So we see locations to the bone and bone marrow, which is the most, let's say, important and frequent metastatic site in neuroblastoma. But we also find the tumor metastasizing to the liver, and we find it also in other areas, in particular local in the dump bell tumor situation, where we have it close to the spinal canal, where it can compress the spine, and this is of course an emergency situation, and at the moment we are working very hard what's the best approach for this spinal emergency. When a patient presents with paraplegia, should there be a primary operation or should there be a chemotherapy, and what's the best way to approach those children? It's not entirely clear at the moment, really, but I think this is explained by that particular location. But of course we have all other areas, and in particular around the celiac trunk, we have a lot of sympathetic nervous tissue. The celiac trunk with the arteries, so the gastrointestinal, the gastric artery that goes right through there. And if we have a big tumor that is encasing this celiac trunk, this is a big complicated situation for local treatment, in particular for the surgical removal. But I think those are, let's say, very typical initial sites. And then, in particular, in patients who have thoracic tumors, we have this Horner syndrome at the initial presentation, where we have this, let's say, impairment of the nerves of the thoracic area that can create this particular presentation at the initial diagnosis. So the take-home message really is that unfortunately the majority of patients have metastatic disease at initial diagnosis, and they are high-risk neuroblastoma. And I give you more details, what's the classification later, but I think if you have a patient that is over 18 months that has metastatic disease is by clinical definition a high-risk neuroblastoma patient. Now, I'd also like to mention here that when we later talk about immunotherapy using anti-GD2 antibody, I'd like to mention that dinutuximab beta was used only in patients that have high-risk neuroblastoma. We are now starting to explore the role also in intermediate risk, because we know that in intermediate risk there are also some patients who really poorly. They have big tumors and they are also eventually threatened by their disease. And here I think there is also a role using anti-GD2 antibodies, but as I said, this at the moment is really a matter of clinical research, and we don't have a lot of data yet in this particular indication. And I would like to make some point about how to make a diagnosis of high-risk neuroblastoma, because there are some criteria that we should follow according to an international structure. And it follows the INRC criteria. So what are these key diagnostic steps? So when we have the typical sign or evidence or the suspicion of a neuroblastoma, which is further supported by the images I show you here on the right side, in particular the raccoon eye symptom, right? So when there's the bleeding into the orbital region, this is a very typical sign, because the neuroblastoma can metastasize to the bone and bone marrow, and it makes a destruction of the bone, and then we have the bleeding from those lesions into the orbit, and this is causing like a clinical sign that looks like battered child syndrome even. Yeah, so one has to think about this very early, and this is a very typical sign of neuroblastoma. So if you see something like this, the very straightforward thing is to do a blood test, because we have the possibility to have tumor markers in the blood from neuroblastoma patients, and the origin of the neuroblastoma is sympathetic nervous tissue. They produce catecholamines, and these catecholamines can be used to make the diagnosis, and you can measure it in the blood but also in the urine. And of course it's not the catecholamines themselves, it's the metabolites. So we use vanillic acid and homovanillic acid that can be measured in the blood and the urine. I think this is very convenient. It's very specific, and this is something that I don't know if you offer this test here also, you send it somewhere, but because it's not so easy to do sometimes. But I think this is very useful suspicion to have a very clear idea. Yes, this is most likely neuroblastoma, and it's not anything else. Of course, then the next step is to do also imaging studies, and of course, depending on where your suspicion is, where the primary tumor is, you do appropriate testing. Ultrasound is helpful, MRI scan of the involved region. What we now try to do is even consider early on a whole body MRI scan, because this is very helpful to do follow-up investigations if you do treatment and to evaluate your response. But sometimes it's not available, and it's completely fine if you do an MRI of your primary region of the primary tumor, to use this for evaluation of your primary tumor response. But you need some type of method to investigate the whole body. And the two options that we have today are listed here. So we have the MIBG scintigraphy. MIBG is meta-iodobenzoylguanidine. It's a substance that is very similar to catecholamine. And the catecholamine is being reuptaken by the neuroblastoma cell. So there's a reuptake mechanism. And therefore, the MIBG is specifically taken up by these neuroblastoma cells, and they can be labeled with a marker. In this case, it's iodine 123, or also iodine 131 can be used. And then this MIBG sends out a radioactive signal, and you can use that signal to detect it with a gamma camera, and you get an image of the disease in the entire body. And that is really important, and it's still a cornerstone on the international neuroblastoma response assessment. for making a category of response. And therefore, the MIBG scan is still very, very important. This may change in the future, but at the moment, what we have to do is MIBG scans to make a proper response assessment when we treat these children. Of course, we have the situation that in about 10 to 15% of neuroblastoma patients, the initial MIBG uptake is negative. So there is neuroblastoma that have no MIBG uptake. And here you need a substitute for the MIBG scan as a method. And here we use nowadays the PET scan. So the PET CT is a good alternative method for this situation. So after the imaging is done, I think what is very crucial as well is to do a thorough examination of the bone marrow. And this is something that is really important. So there is, I think, two key components. One is a standard cytology. So you take a bone marrow, you do a smear, and you check if you find rosette formation. So let's say typical cells that are clustering together, which are typical for neuroblastoma cells. But this is, of course, with a low sensitivity. So you will not find a low amount of cells in the bone marrow. Therefore, we need a more sensitive methods. And this is the second step then to do immunocytology using, again here, anti-GD2 antibodies, because neuroblastoma express GD2 on the cell surface. And then you can stain the cells with an anti-GD2 antibody. And you do then the standard staining methods and you look at the smears or the cytospins and check for the GD2 positive cells in the bone marrow with this method. Now, there's optional methods which are getting more and more important also nowadays, which is looking for specific transcripts from the neuroblastoma cells, which are also derived from the sympathetic nervous tissue characteristics, because these tyrosine hydroxylase and dopa decarboxylase are enzymes which are involved in the generation of catecholamines. And therefore, the PCR for genes that encode for tyrosine hydroxylase and dopa decarboxylase are very useful to measure neuroblastoma in the bone marrow, because normal bone marrow cells usually don't have tyrosine hydroxylase or dopa decarboxylase. Of course, the FOX2B is another, let's say, transcription factor that is specific for neuroblastoma, which has also been established as a good marker. So PCRs for those three markers, for example, are very helpful to test the bone marrow. And if you get a signal, you have a high likelihood that the neuroblastoma is indeed invading the bone marrow. Now, what is also very important at the beginning is to get a genetic evaluation of the tumor, very critical, because we know that some genes are really predicting outcome, and they are also important to be known to make the proper risk group assessment. And therefore, you need to think in such a patient, where do I get my tissue? Sometimes the bone marrow is enough. If you have a lot of bone marrow involvement, those cells can be used to make the genetic diagnosis. But sometimes the bone marrow involvement is very little, and then it's not sufficient. And then you need to get a biopsy from the tumor. And that's very important. You don't just blindly start with the treatment, but try to get some genetic information about the neuroblastoma, because that is getting more and more important also to select certain therapeutics. I mean, we all know about ALK mutation and ALK amplification, which is actually something that should be tested. So it's not on the slide, but I mention it. So ALK should be evaluated, because the ALK mutation, ALK amplification can be treated specifically. And we have other genes that are very important for neuroblastoma, in particular MYC-N. So the MYC-N amplification predicts a poor outcome for neuroblastoma. Therefore, MYC-N amplification should be tested in such a specimen. But there's others, such as 1p deletion and 11q and 17q gain. Now, with this information, so the clinical presentation and also the assessments that I just presented to you, those together will allow you to make a proper let's say, risk group classification. So this has been revised recently. So before we had stage 1, stage 2, stage 2A, stage 2B, stage 3, and stage 4, according to the Evans classification system. Now this has been replaced. Evans is now replaced by this more, let's say, simplified method, but which is completely sufficient to make a good risk group assessment. So what's the new risk group classification clinically? It differentiates between local disease and metastatic disease. Very simple. Is it local or metastatic? Within the local, we define between two options. One is with no imaging-defined risk factors, and two is with imaging-defined risk factors. Now, what is an imaging-defined risk factor? An imaging-defined risk factor is if you make an assessment of your primary tumor, and the primary tumor is encasing major vessels, such as the celiac trunk, for example, or some other regions, then you would classify such a patient in the L2 group versus the L1, where we have not such an encasement of the large vessels. And metastatic disease, we have the classical stage M, which is the high-risk neuroblastoma over 18 years of age. But then there's also the metastatic disease of the small child, of the infant, below 18 months, which is, let's say, a rather benign disease, which does not really need a lot of treatment, sometimes doesn't need any treatment, it just needs watch and wait. And we have let's say, the clinical presentation is also a bit different. We have skin involvement, liver, bone, and bone marrow is less intensive, so we have about less than 10% of bone marrow involvement, and those children would undergo watch and wait, and the other metastatic disease patients would get really intensive treatment. So we have this, let's say, very different biology in this particular disease. Now, this clinical stage is then combined with other criteria, and this is shown on this slide, in this table. It's actually looks a bit complicated, but honestly, it's actually very simple. So we have the criteria of age, histology. We have the genetic information, MYC and amplification, 11q and ploidy, and then on the very right part, we can do the proper risk group assessment. And if you look, if any patient who has a metastatic disease, which is over 18 months of age, is high risk, period. There's nothing that needs to be changed, and that is unfortunately the majority of the patients. So with this information, you already, I think, can localize your patients to a very high extent. Now, there's another, I think, very simple classification, which is if you know MYC amplification, then, and if it is amplified, also even a local tumor, a L1 tumor that is MYC amplified is a high-risk neuroblastoma, because MYC amplification has such a poor prognostic characteristic, and therefore, if you know MYC amplification and you know the clinical status of your disease, you can, let's say, assign about 85 to 90% of your patients. I mean, and then everything else is kind of in between. You can use the table. I also still use it, actually, if there's something intermediate risk or a low risk, and then you can do your proper risk group assessment. Why is this important? It's important because the outcome is so different. So the low-risk patients have an excellent outcome, and the high-risk patients have a very poor outcome, which is shown here by the 5-year event-free survival in these particular slides. Now, what are the common treatment strategies of newly diagnosed high-risk neuroblastoma? And this is now getting a bit more into details. We all follow the same strategy. We use a high-intensive multimodal approach following chemotherapy, surgery, myeloablative chemotherapy with autologous stem cell transplantation, and then re-radiate the patient, and we do a maintenance treatment. So this is all over the planet, is the same thing. What we try to understand is, how is the composition and how is the timing? What's the optimal for these patients? And I bring you one example, which we have been doing in Germany for a long time, NB 2004 trial. And you see here the backbone of our chemotherapy that we are using. It's N5 and N6 chemotherapy cycles with the respective cytotoxic compounds, cisplatin, etoposide, vindazine, vincristine, dacarbazine, and ifosfamide in N6. We give 6 of those cycles, then patients get MIBG therapy, autologous stem cell transplantation. If a residual tumor is there, there's irradiation treatment, and then at that time, 2004, patients would get isotretinoin, which is 13-cis-retinoic acid. Now, in 2004, there was, let's say, a very simple question that was addressed in a prospective randomized clinical trial, which is there a benefit if we add 2 additional chemotherapy cycles to the induction regimen? So in other words, patients would either receive our standard treatment or they get experimental treatment with 2 additional N8 cycles. So we go from 6 to 8 chemotherapy cycles, but everything else is the same. And N8 is shown here. It's topotecan, cyclophosphamide, and etoposide. And the surprising result was that there's absolutely no difference. So the outcome of the extended induction compared to the standard treatment did not show any survival benefit, showing that more chemotherapy in the induction does not help the child at all. We need something else. We need some new treatments, and this is what we are going to talk about a little bit later. So again, more chemotherapy is not the right way for the future. Now, let me make a point about high-dose chemotherapy. I think here that we have 3 randomized trials that actually show that we need, for the benefit of our patients, a high-dose chemotherapy component. So this is a GPOH trial that shows that stem cell transplant versus maintenance treatment shows a survival benefit. This is the green Kaplan-Meier curves. The North American group did the same thing. They have a different induction regimen, but they also showed that the high-dose chemotherapy with the autologous bone marrow transplantation shows a survival benefit. And then there's a European trial that shows that high-dose chemotherapy provides a survival benefit. And therefore, the use of this treatment element is standard for high-risk neuroblastoma, and it should be used. I think what I'd like to do is to share with you some questions now related to how to optimize those treatment elements. And this is now some lessons learned from the current high-risk neuroblastoma 1 study that we have been now our data. So the first question that was looked at was, is there a benefit for the rapid Kojak chemotherapy? Now you see on the top, the rapid Kojak, which is the R3 randomization. It's in that orange type of boxes, which is a chemotherapy that is even shorter compared to what I've shown to you. It's only 80 days. And the courses that are giving rapid Kojak are every 10 days. And the randomized question was comparing it to a standard block chemotherapy, which is given according to the US regimen. It's called modified N7, 5 cycles of a standard chemotherapy, and check for the outcome. The other randomization in this trial related to a high-dose chemotherapy question, comparing busulfan-melphalan conditioning regimen versus carboplatin etoposide melphalan regimen, and looking at the outcome. And the third randomization question was looking at the immunotherapy in this particular trial. And I'd like to share with you the main, let's say, results that came out. Let's start with the induction chemotherapy. So here are some details. So the rapid Kojak is shown on the top. The main difference really is, I said already, it's 80 days only. We have 10-day courses, and the treatment continuation disrespects hematological recovery. So you don't wait until the patient recovers, but you keep going. And the bottom part is, let's say, a standard block chemotherapy, where you give the chemotherapy, you wait for the recovery, and then you give your next cycle. And the duration of that induction is 100 days, and the interval between courses is 21 days. Now, the outcome of this particular trial is also very clear. Even going down to an 80 days induction chemotherapy regimen does not change any outcome. So, in fact, those patients, they are faster through the induction. They have less side effects. They have less time in the hospital. And therefore, the rapid Kojak is the standard treatment arm now in the European SIOP-N group, and is therefore used. So this was, I think, a very important trial result, which is why we now use rapid Kojak in the induction. Now let's have a look at the consolidation. Consolidation is the randomized trial using busulfan-melphalan versus the SEM regimen. And you see the dosage of the chemotherapeutics that were used. And also here we have a very clear result showing that there is a benefit for busulfan-melphalan conditioning compared to the SEM, and therefore we are using the BuMel regimen at the moment for our preparation before we give the autologous stem cells back to our patient, and therefore this is now the standard treatment for these children. Now, I'd like to, look a little bit across the Atlantic what kind of thoughts are going on over there. And I think this is kind of interesting because the Children's Oncology Group actually did 2 transplants and compared in a randomized trial what is the effect of 2 transplantations versus 1 transplantation. And they reported their data also quite some time ago now, but I think the outcome was very interesting, showing that the event-free survival of the tandem transplantation showed a benefit. So it seems that, at least in their, let's say, multimodal treatment, even 2 transplants seem to be better than 1. Looking at the toxicity, this was found acceptable. There was some higher incidence of some mucosal and infectious side effects, which were a bit higher in the tandem transplant group, but overall investigators found this acceptable, and there was a benefit in the event-free survival. However, we are in Europe very careful still. We are not just jumping to this conclusion, because the induction regimen is different. So they use a different chemotherapy frontline, and therefore this trial is now being repeated in the SIOP-N group. Also, there is a randomized question going on comparing tandem versus single transplant, and we wait for the results before we really go for a standard recommendation to do either 1 transplant or 2 transplants. So at the moment, it's just 1 transplant. Now let's have a look at the new treatment aspects, which is now the immunotherapy part for high-risk neuroblastoma. And I think what we should acknowledge is that we have a great opportunity to develop immunotherapies, because neuroblastoma has a very high expression of the ganglioside GD2 on the cell surface, and the ganglioside GD2 is a tumor-associated antigen, so it's not specific, but it's tumor-associated. What does that mean? Tumor-associated means that we have a high expression level on the tumor, but it's also present on some normal tissue, in particular on some peripheral nerve fibers, which explains us why, when we give the antibody, we experience the neuropathic pain, which we need to manage in our clinical practice. The most advanced developed of an immunotherapy at the moment are monoclonal antibodies. However, there is other immunotherapeutic interventions that are on the horizon, and I will share them with you in a bit. They are shown here in summary. So we have the neuroblastoma cell here in the middle, but there is a lot of different options how we can use the GD2 expression to attack it with certain immunotherapeutic interventions. We have the anti-GD2 antibody naked, but it can be conjugated with radioactive compounds. It can be conjugated with cytotoxic compounds. And of course, the variable region of the monoclonal antibody can be used to make chimeric antigen receptors, which are transferred into T cells. And we have now the CAR T cell therapies that are also coming up as an option, and we will see about that in a bit. Also, I have some reflections about the CAR T cells in my presentation. However, we also have vaccines, which I think is interesting to look at in the future. So what is a vaccine? A vaccine is using the ganglioside GD2 itself, or, this is our development, we use an anti-idiotypic antibody, which is a protein that mimics the GD2. GD2 is a glycolipid, so we have a carbohydrate antigen that is recognized by the antibody, and carbohydrates usually are poor immunogens, and therefore we made a mimic of this carbohydrate and made a vaccination approach to induce an antibody against ganglioside GD2 and study this in patients. So there's a lot of things that are happening. However, of course, the most advanced immunotherapies are GD2 monoclonal antibodies, and of those we have dinutuximab, we have dinutuximab beta, but also we have naxitamab. Those are the 3 possible antibodies. Now let's have a look at what is the effect of the treatment, and this is a slide that compares the outcome of the trials that have been done in North America using dinutuximab with IL-2 and GM-CSF. And on the right side and the left side, we see the effect of dinutuximab beta in the SIOP-N studies. And the children oncology group was starting earlier in 2002 and 2003. They already had their trial open, which was first reported in 2010. And they recently showed their long-term follow-up data, which is shown in this particular Kaplan-Meier curve. So the difference of the immunotherapy is still detectable. So patients benefit from from the immunotherapy with a 2-year event-free survival at 66 plus minus 5%. However, if you see it to the right side of the Kaplan-Meier curve, you see that there's a convergence of the curves. So therefore, so we have these late relapses after completion of the immunotherapy. So we need to think about what to do about that. Do we have to treat longer, or do we need to do something else after the 5 cycles of dinutuximab beta is, let's say, challenging our minds at the moment. But we can also learn something else from this comparison, which is that if you look at the left side, the 2-year event-free survival using dinutuximab is 65 plus minus 2%, comparing very nicely to the dinutuximab plus IL-2 plus GM-CSF. And so it's almost the same, let's say, outcome, but it doesn't require any cytokines. And I think that's the big take-home message here. So we don't need IL-2, we don't need GM-CSF to get the same effect like when we look at the data from our colleagues. I think this is, let's say, the core data to support us to use dinutuximab in the maintenance phase of high-risk neuroblastoma. Now let's go back to the high-risk NBL1 study. So there was a randomized question looking at the role for interleukin-2 for the additional treatment with dinutuximab beta. And the idea to give IL-2 is very clear, right? IL-2 is a very strong cytokine, and it can activate natural killer cells. And the natural killer cells are the driving effector cells that, together with the antibody, mediate an antibody-dependent cell-mediated cytotoxicity against the neuroblastoma. And in all preclinical models, we can show that, in fact, if we give IL-2 combined with anti-GD2 antibody, we get a better effect against the neuroblastoma in mice. But we see here the clinical reality. It doesn't translate into a benefit for our patients. So patients who get the IL-2 have exactly the same event-free survival and overall survival, indicating that there is absolutely no benefit for adding the interleukin-2, which was a surprising result because we expected that there would be an advantage. And we started to look at possible explanations why we don't see that IL-2 effect. And what we found in patients that receive dinutuximab beta with IL-2 is that we see a very strong upregulation of regulatory T cells. And this is shown here. So you see on the left curve the time of 5 cycles of dinutuximab beta combined with IL-2, and you see after the first application of IL-2, we see a very strong upregulation of the regulatory T cells, and they go down before the next cycle starts. But if you look at the through levels, the baseline is never reached. So we have a constant increase of regulatory T cells if you treat with interleukin-2. And this is also reflected by the Kaplan-Meier curves on the right side. So the patients who have a very high count of regulatory T cells who receive this treatment, they do very poorly. They have a very poor outcome compared to patients who have a low regulatory T cell count, who have a very good outcome. And that, I think, is an explanation why we don't see that beneficial effect of IL-2, because we have the Tregs that counteract this effect of the interleukin-2. And I'd like to make a short reflection about GM-CSF. We don't use GM-CSF, yeah, but a lot of people do it in North America, for example, and also with naxitamab, I think GM-CSF is combined. And but here we have a very similar situation. So GM-CSF also is a very beneficial cytokine. It can upregulate effector cells that drive an ADCC response, like neutrophils or monocytes and macrophages. They make a pro-inflammatory environment. However, it also has this double-edged sword characteristic. So at the same time, it also upregulates immunosuppressive molecules, such as a nitric oxide or IDO. PD-L1 is upregulated. GM-CSF upregulates regulatory T cells. And we also find immunosuppressive cytokines following GM-CSF treatment, such as TGF-beta, interleukin-10, and all these factors most likely also counterbalance the possible beneficial effect for the GM-CSF. So my personal opinion or assessment for the GM-CSF is that most likely this is also not needed. So you don't need GM-CSF because you have a good and you have a bad part, and at the end it doesn't really play out for the benefit of the patient. However, there's no randomized trial anywhere in the world comparing antibody with GM-CSF versus antibody alone. Nobody has done such a trial, so we don't really know clearly if it's actually true, but I think this consideration and also looking at the IL-2 randomization data is a very strong point for not giving GM-CSF because you have these bad effects also that come from the GM treatment. Now, I'd like to make a very quick point about new data that we learned from that particular trial. I think what I did not mention yet is that we use dinutuximab beta in two ways of application. We did in the past give dinutuximab beta as short-term infusion. So we give 20 milligrams per meter squared on 5 consecutive days as an 8-hour infusion. And then we switched to the long-term infusion, giving the same cumulative amount of the cycle, but not in 5 days, but we give it continuously over 10 days. And this is shown here. And we learned, or we did this because we can really improve the side effects of the dinutuximab beta treatment. So we have less pain, we have less inflammatory side effects, we don't need so much morphine to manage our patients, and the patients can get this treatment outpatient, carrying a pump where this antibody is delivered. They run around the ward and they are completely fine. So it has really a benefit in terms of making the treatment more tolerable. But now we assessed also what does this mean for the outcome. And we found a very interesting result, which is that patients who get the dinutuximab beta as long-term continuous infusion, they have a better event-free survival. It's even statistically significant. So with a p-value of 0.41, long-term infusion provides also a better outcome. So it's not only more tolerable, but it's also better for the child because we have a higher likelihood that we prevent relapse if we give it as a long-term infusion. Now, it's a very interesting question now, why is that? And this is at the moment something we still need to put more investigation into. So there's a possibility is that we have a beneficial pharmacokinetic profile. So because we have a longer or better exposure to the antibody, if we give it over a longer time period, this could be one explanation. Or it could be an explanation that the treatment tolerance explains why we have a better outcome, because more patients can accept a sufficient amount of antibody to over this long time period of 6 months of the maintenance treatment. So those are the two main, let's say, pathways that we are looking into our data, and hopefully we have them ready for presentation then at ASCO or ANR this year. So long-term infusion of dinutuximab beta is associated with the survival benefit, and I think that's important. Now, I'd like to then, put this all together, this information, and explain to you the current high-risk neuroblastoma 2 trial. So I spoke about the one. Now this is the new high-risk neuroblastoma 2 study as it is running right now. So we have, again, a randomization question in induction. So rapid Kojak is being tested against the GPOH induction regimen. This has a very some important reason, because the GPOH induction has been used for 30 years in Germany, and we have very strong response and outcome data. And therefore, I think it was very important, because Germany now joined the SIOP-N group to actually test the German induction versus the rapid Kojak and see what is going to be the outcome. The randomization is closed already, and we will hopefully have some meaningful data coming out from this particular randomization. There is a second randomization going on. I mentioned it already. So based on the US data of the tandem transplant, there is a randomization of 2 transplants versus 1 transplant going on. And finally, there is a local therapy randomization. So patients with a residual tumor will be randomized to either receive a standard dose, or they get a standard dose plus a boost to the residual tumor of 14.4 Gray. And this is also, I think, a very interesting question to see if there's a benefit to prevent local relapse if the patients get this type of management. And then the maintenance treatment is listed here. I'd like to make a quick point about the 13-cis-retinoic acid. It's still part of the maintenance. It's combined with dinutuximab beta. There's a debate of whether this is meaningful or not. I mean, it's done in the European group. In Germany, we decided to skip it based on the meta-analysis that have been conducted. So if you look at all the studies where 13-cis-retinoic has been given, including the randomized trials that have been reported from COG, there is little, if any, evidence left that this 13-cis-retinoic acid really adds to the benefit for the patients, and therefore we decided in Germany not to give it anymore. But this is, of course, let's say an open point. I don't know how you do it here. If you give 13-cis-retinoic acid combined with dinutuximab beta, but I mean, I think it's probably for the patient doesn't make a big difference if you give it or you don't give it, if you have available dinutuximab beta. Yeah. If you don't have it, of course, then you would give it. I mean, this is clear. Now, the one, I think, a new part of this version of the protocol is that patients who have a poor response following rapid Kojak or GPOH induction are eligible to receive 3 additional Temiri cycles. The idea for the trial is to rescue some patients to meet eligibility criteria for the randomization for the high dose question. The eligibility criteria is a SIOP-N score of equal or below 3. Now let me go back to the tandem transplant and the immunotherapy. And I think this is something that this is very important to understand, because if you give high-dose chemotherapy, of course you, to some extent, downregulate the immune system, right? I mean, you are immunosuppressive, and therefore I think it is important to understand that if you give 2 transplants, you may be worried that by doing 2 transplants in a row, there's nothing left that you can use for driving the immunological effect to combine it with the immunotherapy, because you need effector cells. If you don't have effector cells, then this treatment is not working. And therefore, COG did a very important subgroup analysis looking at patients who get the tandem transplant in combination with the immunotherapy. And they can clearly show, if you look at the right side of the Kaplan-Meier curves and compare it to the left Kaplan-Meier curves, that the curves move further up. So giving a tandem transplant, so it gives combined with immunotherapy, has a 3-year event-free survival of 73.3%, and if you don't give the immunotherapy, it's 61.6%. So yes, the immunotherapy further adds to the survival, although the patient gets 2 transplantations. So that's important. So there's a real option also for us in Europe. I mean, if the trial results come out in favor for the tandem transplant, it makes sense to give the immunotherapy, because the effect is maintained as shown here in this particular study. Now let me close this part by looking at the frontline use of dinutuximab beta, sharing with you this epidemiological assessment, and it shows that since the introduction of anti-GD2 immunotherapy, we see a steady increase of the overall event-free survival. Look at the era of 2010, and these Kaplan-Meier curves clearly show that we are moving further up, indicating that the addition of that treatment really makes a difference for the children with high-risk neuroblastoma. Now, I'd like to summarize this first part. How much time do I have, anyways? Until 2 o'clock? Or can I do longer? Because I have 3 parts, but I have to speak quicker. Anyways, so 15 minutes? Okay, that's good. So then, the summary of the first part is we seem that there is a benefit for a short intensive induction, so it doesn't make sense to give long induction regimen. The rapid Kojak is standard at the moment. We have also learned that the high-dose chemotherapy is really important for the management, and maybe 2 is better than 1. We don't know, but we will see how the trials will turn out. But you need 1. I think that is very clear. And then the anti-GD2 antibody therapy is standard for the management of high-risk neuroblastoma. In the maintenance phase, there's no benefit for IL-2, and the long-term infusion is, I think, the clear way how to give it, because we not only have less side effects, but we also seem to have a benefit in terms of outcome for these patients who get dinutuximab beta this way. Okay, so then let me talk a little bit about relapse refractory disease, because this is, I think, a bit more challenging, because things are not so standardized at the moment. And it starts with definitions which are not so clear also. What's a refractory patient? I mean, relapse, I think, is more easy because you can, let's say, make a diagnosis of a new occurrence of the disease at any time point of the management is called a relapse disease. But then what is refractory? Refractory is, I think, defined here as incomplete or no response to a standard treatment of high-risk neuroblastoma. But how do you define incomplete response? And here it gets tricky, right? Because it's kind of variable. Is it a partial response, or is it an insufficient response? Is it a very good partial response? What is incomplete? And this makes it so difficult if you look at clinical trial data, because they are kind of mixed together all the time. And when we look at the outcome, we clearly see a difference between relapsed and refractory, but they are still kind of put together into one basket. And I think this is something that we need to change eventually for the future. I put also a Kaplan-Meier curve here, which I depicted from a retrospective historical analysis done by the Children's Oncology Group, where they looked at all their relapsed refractory disease patients who were recruited into phase 1, phase 2 clinical trials. And they looked at the outcome, and they come up with this Kaplan-Meier curve, which is really, let's say, a very poor outcome. So if you look at the progression-free survival, at 4 years, it's 5%. At 1 year, it's about 20%. And when we look at amplified versus non-amplified, we see that the amplified patients are really doing even worse. So they go very rapidly to zero. So there's so this is, let's say, the cornerstone and also the comparator for when we do clinical trials. We get, we have to compare to this standard in terms of outcome we are getting with our studies. Now, the more we learn about the management of a relapsed neuroblastoma is that we can do much better than what is shown here on these curves. So we have now tools, in particular the use of dinutuximab beta in different scenarios in the management of relapsed refractory disease to really push that curve up. And I mean, there's some combinations where we can reach up to 60% overall survival in patients who receive certain combinations. And I'd like to share with you that data in the next 10 minutes. However, what we also learn is that we need a structured approach to the management of the relapsed and refractory disease. So it follows the similar logic like in the newly diagnosed. So we need a reinduction therapy using an effective second-line treatment. And then it also will involve a consolidation. I think that is important to understand. It doesn't make sense if you have a treatment that works in relapsed refractory disease, like a chemotherapy combination, and then the patient responds. And then if you just keep going with the same type of treatment, you know what is going to happen. There will be resistance developing, and then the patient will relapse and progress again. So we need to switch to something else, and we need to consolidate something. We need consolidation strategies, and then we need also a maintenance in the relapse refractory situation when we completed our consolidation. In all those phases, the dinutuximab beta has shown to be of benefit, and I think that is important to understand. Before I jump into details, I think I'd like to make a strong point about a rebiopsy. So if you have a patient who has a relapsed neuroblastoma, you need to check your genetic composition of the tumor. Very critical. Because we know that patients who, for example, are ALK negative at initial diagnosis, they may recur with an ALK mutation and an ALK amplification. And then you have right immediately you have a treatment option for your relapsed neuroblastoma. So it's absolutely not advisable to blindly just start your relapse strategy. Check your tumor, check the genetic composition, and then make an educated decision what's the best way forward. Because if you have an ALK amplification, you want to add crizotinib or lorlatinib or some ALK inhibitor in your management. So it's very important to actually not forget it. Okay, a very important component to reinduction in a relapse refractory disease is chemoimmunotherapy. And I have brought some preclinical work that underlines that assumption, which is shown here. We know today that chemotherapy not only is cytotoxic, but it has immunological effects. And this is shown here in this publication. There's a graphical abstract that we did, and it shows that the chemotherapy does a lot of things to the microenvironment, but in particular it upregulates stress ligands on the tumor. And these stress ligands, they further increase the activation of immune cells, in particular natural killer cells. And you remember, the natural killer cells are the driving cells that mediate the ADCC response. So the antibody combined with NK cells activated through a stress ligand have a better effect against the tumor, which is why there is a synergism of giving antibody with chemotherapy at the same time. And we've tested this in many different models, and I think just to briefly explain what you see here, it's a sphere of a neuroblastoma. So these are, let's say, neuroblastoma spheroids. They are generated from cell lines which we grow in the petri dish, and these are about 5,000 neuroblastoma cells. And we combine them with the chemotherapy, but also with leukocytes, and we add the antibody to it. And what we see here in the readout is that these spheres, they are nicely killed when we give the chemotherapy combined with antibody and the leukocytes. This is the bottom part. And the medium part is the cisplatinum alone. So we see here a reduction of growth, but there is some growth going on. And the medium control, of course, we have a rapid increase of the spheres over time. And if we test this, not only for cisplatinum, but all other cytotoxic compounds that we are using for the neuroblastoma treatment, we see a synergistic effect. So there is a combined effect using the antibody with leukocytes and the chemotherapy, and we have a synergistic combination treatment effect for this setup. And of course, this also translates into the clinical scenario. So I brought some examples to show this to you. So the first example comes from the Beacon Immuno study. So this is a PSYOP-N trial, phase 2, randomized, looking at a combination of dinutuximab beta with topotecan and temodal compared to no dinutuximab beta, but giving the chemotherapy. And we see there is a clear doubling of the response rate when we combine the dinutuximab beta with the chemotherapy. I also like to briefly mention the dose. You see the dose in this trial was 70 milligrams per meter squared. Why is this? The dosing depends on the treatment interval. Okay. So remember, in the maintenance, we give dinutuximab beta every 5 weeks. So we have 100 milligrams per meter squared. Here we give it every 4 weeks. So we give 70 milligrams per meter squared to match the pharmacokinetics. If we give chemoimmunotherapy in 3-week interval, we give only 50 milligrams per meter squared. So it really depends on the interval that you are planning for your chemotherapy in terms of the dose for the dinutuximab beta. And in this trial, it was 70 milligrams per meter squared. And when we look at the progression-free survival, also here we have a clear benefit for patients who get the dinutuximab beta combined with the topotecan temozolomide compared to the control arm. It didn't translate to overall survival because patients were allowed to cross over. So if the patient has an event with chemotherapy alone, he could switch over to receive chemoimmunotherapy. This is why we don't see overall response benefit for the combination. However, there's of course now a lot of so-called real-world data that are being reported. Our Turkish colleagues did some exercise along that way using 3-week interval irinotecan temodal combined with 50 milligrams per meter squared of dinutuximab beta, reporting an objective response rate of 63%, and within that there's 32% complete responses. And we did a similar exercise with 25 patients reporting exactly the same data. 64% objective response rate with 32% achieving a complete response. So this is very reassuring that this chemoimmunotherapy is a very good option to treat these patients. However, once you reach a good response for your patient, I mentioned earlier, the North Americans, they just keep going treating with chemoimmunotherapy, and then at some point it's over, and then the patient relapses. So we need to think about some consolidation approach. And here, I think we have explored something which is very interesting, looking at the use of haploidentical stem cell transplantation. And the idea behind that is that when the patient achieves a complete response, after a second-line therapy, we give the patient a new immune system. That's the idea behind the haplotransplant. It's not giving another second high-dose chemotherapy. It's to prepare the child to accept the cells from the parents and then have a new immune system to again treat with dinutuximab beta after the recovery of the patient. And this is the idea here. So the leukapheresis is done, but then we do a CD3, CD19 or T-cell receptor alpha beta CD19 depletion to get rid of the T cells. Why? The T cells are problematic in a haplotransplant because they drive graft versus host disease, and we don't want to have that cell part in our graft. But we have a lot of NK cells remaining, and this is very nice because the NK cells are driving our effect together with dinutuximab beta, in particular if they come from father or mother, because they are KIR ligand mismatched. The KIR ligand mismatch, they have a further let's say activation and a better effect when we use it with dinutuximab beta. Now this is the trial design. So the haplotransplant was given, and then patients would receive 6 cycles of dinutuximab beta. It was the old short-term infusion in the trial because it started 2010, and at that time we still working with the short-term infusion of dinutuximab beta, and in the cycle 4 to 6 we also have still the IL-2 in this particular trial because the randomization results with the IL-2 were not available when this trial was planned. Okay, what's the outcome? The outcome is that we have a very nice response rate looking at the patients who have evidence of disease with 51%. Within that, we have 35% who have a complete response, and the survival is also excellent. So patients who get the haplotransplant with dinutuximab beta, they show a clearly statistically significant superior survival compared to the haplotransplant alone control group. And I think take-home message was that this is a really nice consolidation part. Now let's talk about maintenance. So when the patient goes through all that package and is fine, we should continue some therapy because then the patient already had a relapse, so you want to prevent a second or third relapse even. So therefore, the maintenance with dinutuximab beta is really interesting option again, and we did a trial in this context. It's called the 304 study, where we exactly looked at such patients. And the rationale was that for that trial was that up to this point, dinutuximab beta was always given with something in combination, either with cytokine or with chemotherapy or even with 13-cis-retinoic acid. And here, this is now a study where we only did dinutuximab beta alone in a long-term infusion way, and we assessed certain primary endpoints, which was response rate, but then secondary endpoints was safety, progression-free, and overall survival. Now let's first have a look at the response. The response was really excellent, so we see 37% response rate. When we include the minor responders, which is a patient who responds in the MIBG scan but still has a stable disease in the soft tissue, you can count them as a minor responder. Then we have 53% response rate in this particular trial. And if we look at the bone marrow response was also excellent. So in patients who had a bone marrow disease, when we upon recruitment to the study, 93% of these patients responded to the bone marrow. So it's an excellent vehicle that can be used for treat the bone marrow disease, which is clear because the bone marrow is semi-solid, right? It's easy reachable by a monoclonal antibody, and therefore the let's say the attack of such cells is facilitated, and therefore we have a good bone marrow response. Survival is also very good, and here's this example I mentioned earlier. When we look at the refractory versus relapse population, we see that the relapse population does worse than the refractory. So those are different patients, but still we put them together for future. Maybe we have to separate them into different groups or different trials even. But look at the overall survival rate, 3 years. It's 66%. Yeah, so this is really a good number, and therefore I think it's very important to consider this treatment for these children. And I'd like to compare this actually to CAR T cells, because the CAR T cells are now very en vogue, let's say. I mean, we all know about the great work from Franco Locatelli and De Buffalo and the group, and they did excellent work with using a GD2 CAR T construct, using, by the way, the variable region of dinutuximab beta. So the recognition site of GD2 is exactly the same like the antibody. But of course, then they have the CAR construct using 2 co-stimulatory domains, so CD28 and 41BB zeta. And they showed for the very first time that in a solid tumor, CAR T cells work. This is why you get the New England Journal paper with 27 patients. Yeah? This is the big news. But if you compare the outcome with what we can achieve with antibody, then it's not so clear anymore. And I'd like to share with you this reflection. So they report in the trial overall in event-free survival, which is at 27% at 3 years. What they did very honestly is they looked in their population at patients who have a high tumor burden compared to a low tumor burden. And they show very clearly that patients with a high tumor burden, it doesn't work, the CAR T cells. It only works with low tumor burden. So what does low tumor burden in that trial mean? It's a CyOP-N score of 7. Okay, a CyOP-N score of 7 is like 7 spots on an MIBG skeleton. It's not a lot of disease, okay? And an antibody works very nicely with I think 7 MIBG spots in a scan. So therefore, I think one has to be very careful, to be over enthusiastic about this. I mean, I think it's very great. We have now a new treatment, and I think it should be pursued, maybe optimized also, combined with some things. But at the moment, for me, it's not a reason to send everybody to Rome to get CAR T cells, because with the antibody, it just works as well. And this is a table that shows that. So I did the exercise to compare some phase 2 clinical trial data that were reported in the literature, and looking at the patient population, the response rate, event-free and overall survival, and the respective references. And when you look at the response rates and the event-free and the overall survival, the best, let's say, outcome data that were reported, the strongest effect size was really for the Haplo plus DB study, followed by the 304, followed by CAR T, and the worst outcome was actually with naxitamab and GM-CSF. Yeah? And I think this is, therefore, I think we feel very comfortable doing the Haplo trial at the moment. Okay, so 15 minutes are over. I have a lot more to say, but I'd like to stop here and just mention quickly that we have also compared naxitamab with dinutuximab beta. And this, I don't know if this is an issue for you, but we found some very nice preclinical data that the effect of dinutuximab beta is about 5 to 10 times higher compared to naxitamab. So there's no reason to really switch to naxitamab or to do anything with this particular molecule at the moment. So thank you very much for your attention, and happy to take questions if you may have any.
Well, I'm amazed, first I should say, because when you are in a position of being every day with standard patients, and when you hear a lecture like this, then you feel alive, because we also like research. I'm leading the neonatal and pediatric intensive care unit, and I know you're intensivist as well. So I will take an advantage of 2 patients that I have down there. But my question would be, how would you know which kind of biological therapy you would use? For example, in this neuroblastoma that you might not get with the rituximab, that's what you want. It could go to another place maybe, or not to be used on the right place. How are you sure that with the biological therapy, you get what you want?
Well, there's unfortunately never 100% in life, right? And also in neuroblastoma, it applies in particular. But I think with the dinutuximab beta or the anti-GD2 therapies, we have very nice tools, because the GD2 is so highly expressed on neuroblastoma. And even if you have a GD2 analysis on a relapse patient, it's still very high despite the fact it has been given before. So we think we are very, let's say, safe to do the right thing if we give an anti-GD2 antibody again, because we have this robust GD2 expression. With other biological therapies that we could think about in neuroblastoma, it's more difficult, right? We have bevacizumab, for example, which is let's say, an angiogenesis inhibitor. There are some, let's say, not so strong data, but there are some data that there may be some benefit to give bevacizumab, but I'm honestly not so convinced when I look at chemoimmunotherapy using the dinutuximab beta combined with this chemotherapeutic compounds. And then there is the targeted therapies as well, right? I mean, this is why I think it's so important to to do a biopsy again of the tumor. So if you identify certain targets, I think then you can select from small molecules that are targets for the genes that you have identified. This would supplement your treatment. I would probably not skip the biological treatment. I would combine it, right? So I mean, if you have an ALK mutated tumor, I would give the chemoimmunotherapy and add in the ALK inhibitor. And
I did understand that.
Yeah.
And what about the survival rate? What about maybe which one is the youngest child that you have had, or a baby that has survived?
Oh, I have. The youngest baby that has survived. I have a lot of that survived. The youngest, I would need to go back really honestly, but I would under 1 year, I think,
with
for sure.
Everything normal,
yes.
with all the neurological outcomes.
Okay,
I'm just interested.
Of course, there is. Of course, I mean, honestly, there is some sequelae. I mean, if you give the high dose, the multimodal treatment, the hearing is a big issue. Now we have this new drug to protect from hearing loss. Have to be careful because you also inhibit the effect of the chemotherapy to some extent. So at the moment, I think it's not approved for patients to be treated at the initial diagnosis, but for some, I think, later phases, you can give the this. So of course, those patients have problems. I mean, this is very clear, and therefore it's so important to also start thinking about, can we replace some of our toxic treatments with biological treatments? These are exercises that we need to do in the future. I'm aware of one trial which is going on in the United States, the Children's Oncology Group. They are randomizing high-dose chemotherapy versus chemoimmunotherapy. So they would not give the high dose in one arm, but give dinutuximab, so their anti-GD2 antibody with chemotherapy, and in the other arm give the high dose. So this would be one example to try to detoxify the treatment in the future. Yeah.
At first, let me express my gratitude to be here and to have a nice lecture. And as a head of Department of Pediatrics, I would like to thank all the members of our department. And we have very big collaboration, gastroenterology, as a head of gastroenterology department and hemato-oncology. And also, I remember that we have also children which start with abdominal pain, and after ultrasound we found that this is neuroblastoma. And yes, and all that procedure. About that we have a little bit more experience about neuroblastoma with biopsy, liver biopsy, etc. And I hope that I saw that you had a more presentation, more slides here. I think this will be good beginning, and you will come again at our department, and you will take a lecture in the future again, because I saw that you
there's some more, yes,
of
course.
And Germany is very near here.
Yeah, that's true.
You have this and this.
Now we give a new line.
Yeah, new line. Yeah.
Very close, yeah.
The first patients you have at the oncology department, after that at the intensive care unit. I hope that we have also the gastroenterology, and this could be also beginning not only for the Department of Pediatrics, but with other departments at the University Children's Hospital. Welcome, and on summer we are going to Ohrid.
To the lake, yes.
I want to say that, as you know, we have experience with treatment with the dinutuximab beta in our department. We start with this therapy 3 years ago for all of our highest patients. So we have a very good experience, and we are satisfied with this therapy.
Good.
One of our patients received dinutuximab beta as a maintenance therapy now in this period, and second highest patient we are treated with a combination with chemotherapy and dinutuximab beta because of the resistant disease in the conventional chemotherapy. So our experience with this is good. In the last 3 years, I can say that all of our patients are alive.
Very good.
question is, you say that N-oncogen is very important prognostic marker for high-risk patients. So my question is this enough to detect only the presence of N-oncogen in the tumor of bone marrow, or is it important to determine the copy number of N-MYC? Does the copy number have impact on the prognosis of the disease? Because we check only for the presence of N-oncogen.
Yes, I think the copy number is important as well. You need a clear, assessment. Do you have a copy number that is above a certain threshold, which is I think 20? So if it's above 20, you can call it MYC-N amplification, and that would be categorizing a patient as high risk with a local disease. If it's metastatic, it doesn't matter, right? You have high risk anyways. But of course you need to. I think the cutoff is 20. But I think it's not only MYC-N that is important, right? We should also look at these other genes that are important. I mean, I listed a few of them, but there's of course more that one could think about. TERT is important. ALK, I mentioned already. 1P, 11Q, 17Q. I think this helps you to understand the risk profile better. But at the end, to make a risk group assessment, I think MYC-N is very important, and if you have that clearly, then it's already, most of the patients are covered. Do you do this in-house, or you send it someplace?
No, in our institution you can check only for the presence of family, but we can check the copy number in the research center for genetic engineering, so we can do this.
Yeah.
Thank you. I have more questions, but I will leave for the department.
Okay.
Thank you very much for your presentation. Darling, do you have any questions? If not, I want to say once again, thank you very much for your excellent lecture.
Thank you too. Thank you for having me.